answer of the question you are asking. So basically, if you look here on this karyotype, this, my friends, is the whole genome of a single tumor cell. So, we talk a lot about single cell genomics. Now, this is single cell genomics at its very basic form. Of course, the sensitivity is low. You cannot go and identify minor abnormalities. But what you looking at here is the whole genome of a single cell, and you can kind of explore as what can be the different abnormalities in different chromosomes. And by identifying the chromosome locations, you actually identify the abnormalities that occur in the genes. Whereas fish, you just use a specific probe, you ask a specific question, and fish will tell you yes or no. And then you will know whether that specific abnormality is present or absent. So here you have added the probe, and these are nothing but nucleic acids with fluorescent tags attached to it. They will go and home into the location, and then you read under the microscope. Now, the most common fish any cytogenetic lab does is for BCR-ABL. So when a patient of a suspected myeloproliferative neoplasm comes, what do? We just take the peripheral blood and we just do a fish using the BCR-ABL probe. Now, this is how the probe is designed. The chromosome 9 has the ABL1 gene and it has a red fluorescence. The 22 is a BCR gene and that's a green fluorescence. So normal cells will have 2 copies of genes, so you'll get 2 reds and 2 greens. The moment there is a reciprocal translocation, what you will see under the microscope are you will see fusions or yellow signals, and you will see 1 copy of the normal 9 and the normal 22. Well, it is not so simple. When you start fishing, you realize that there are a lot of variant patterns. This is a paper we published when I was in CMC Vellore. It has signal patterns of more than 1,500 patients. So you can see there are different patterns you may see. You may see subclones, you may see more than one patterns, and it is very essential to record even the atypical fish patterns that you're seeing, because when a patient comes on follow-up and you have to fish it, if there is a change in the signal pattern, you need to document to show that probably there is some genetic evolution going on. I'll show you an example. So for all those who are interested, they can refer to this paper, which gives you a complete idea about the different patterns of fish you will see when you use a BCR-ABL. Now, let me show you an interesting case. I like to name my cases, and this case I would like to say, when you jump signals, will tag to a BCR. So whenever you get an MPN, of course, you look for a BCR-ABL that was negative in this patient. And then molecular studies were done where JAK2 mutations, MPL mutations, and CALR sorry, were all negative. So when we did the BCR-ABL at our hospital, we saw that this patient has 3 copies of BCR gene and 1 copy is a small one. So we gave it as BCR-ABL negative. Now, the treating physician, so what you see here on the graph, you see the dates here, and these are the WBC counts here. So the treating physician, what he did was he read the report in a wrong way. So we said the fish for BCR-ABL is negative with 3 copies of the BCR gene. He misinterpreted the result as positive and started the patient on imatinib. The moment he started the patient on imatinib, the patient responded very well and the counts came back to normal. On the next OPD visit, what happened was this guy was on leave and there was another doctor sitting there, and he realized, hey, BCR-ABL is negative. Why was imatinib given in this patient? So then he stopped imatinib. And next, when the patient came back, the count went up to 50,000. So we got a call from the clinic. What are you guys doing? The BCR-ABL is negative and the patient is responding to imatinib. So I said, okay, do one thing, send us peripheral blood or preferably a marrow for karyotyping. So as the guideline says, at diagnosis in CMLs, you should do karyotyping, but with the numbers we have, it is very difficult to do that. So anyways, we karyotyped this patient, and what we found here was a 422 translocation. And what you see here at 4q12 is where your PDGRF alpha gene is present. So this patient had a PDGRF alpha gene rearrangement. So you must understand that PDGRF alpha and beta, both of these can be seen in myeloproliferative neoplasms. The spectrum can be varied. They commonly present with eosinophilia, but sometimes you can see a different spectrum. And in these cases, these patients too respond to tyrosine kinase inhibitor. Now let me show you some other cases of chronic myeloid leukemia. Now this was a patient of CML who was showing major molecular remission on the BCR-ABL real-time PCRs, quantitative PCRs. Now he was having persistent cytopenia, so the karyotyping was sent to us, and what we saw was that the 922 translocation was not present. That means the imatinib or the tyrosine kinase inhibitor had worked. That's why the patient was in molecular remission. But there was a new clone which showed a trisomy 8. Now, when you look at patients of MPNs, their peripheral blood marrow can show some amount of dysplasia. And now the patient was also on a TKI, so it was thought, okay, the dysplasia may be because of the therapy or a part of the MPN. But what we found here was a trisomy 8 and there were features of dysplasia. So what we are dealing here is a elderly with CML on imatinib major molecular coming with cytopenia. You do a karyotype and you find a trisomy 8 which can be seen in myelodysplastic syndrome. So this patient was actually having an MDS and that was responsible for its cytopenia. So he was put on alternative treatments and then he started responding. Now, this was again a 23-year-old CML patient on treatment, responding well, but started having persistent low platelet count. A karyotyping was sent to us. So what you see here in the arrow is a translocation 922, which is diagnostic of chronic myeloid leukemia in myeloproliferative neoplasm. But as I said, karyotyping, you're looking at the whole genome of a single tumor cell. What we also found was that this patient also had inversion 60. So we called the doctor and said, hey, this patient also has an inversion 16. So, there is a genetic evolution that has happened, and this patient would be still wasn't in a blast crisis, but would be going into a blast crisis. And we have identified an inversion 16. Now, inversion 16 is also diagnostic of acute myeloid leukemia. So initially, it was only 821, inversion 16, and PML-RAR or 1517. But in the new WHO 2022, AML with defining genetic abnormalities, when you have any of these, then you do not need a blast percentage of 20%. So eliminating the 20% blast requirement has been there, except in AML with BCR-ABL fusion, because this could be in CML, and AML with a SEPA mutation, right? So you have to integrate clinical, molecular, and genetics in order to reach your complete diagnosis and characterize the hematological neoplasm. So this brings us to a question: do we need a blast? Of course, this is the blast we always want to have. This is the kind of blast we wouldn't love to have, and our life usually as pathologists deals with these kind of blasts that we see on a day-to-day basis. So just show you with an example, it was a 14-year-old girl who actually had, their whole family had viral fever, and in fact the whole family had low platelet count when they had viral fever. So by the time the viral fever went away, the platelet counts of other family members recovered, but this girl continued to have low platelet count. And so we did a bone marrow aspirate, and what you see here in the bone marrow aspirate is hemophagocytosis. So what you see here, you see this is the histiocyte and it has eaten two neutrophils. Look here again, it has eaten a myeloid precursor. So there was rampant hemophagocytosis going on, which can be seen in viral diseases, right? And you can see, and then we saw these cells where the granulation looked abnormal. So we knew something was going on. Blasts were less than 5%. A flow cytometry was done, which again didn't show any increase in the blasts, and there was myeloid dysplasia features on flow cytometry, but there was no increase in blasts. And when we did a karyotyping, we got a translocation 821 with deletion 9q. So as I said again, the presence of 821 is characteristic and diagnostic of acute myeloid leukemia. So when we told the treating physician, his first question is, how do I counsel the family? Telling them that, look, we have tumor cells here. I mean, we do not have tumor cells, but we need to treat this patient with intensive therapy. And also the problem was, usually when you treat a patient of AML at the end of induction, You look for morphological remission in the marrow with less than 5%. Here, the blasts are already less than 5%. So, how do you follow up this patient? So, these patients can be followed up by actually looking at the genomic abnormalities. And the response to treatment can be done by looking at the 821 either by FISH, or you could use molecular techniques like digital droplet PCR, or if you have a real-time PCR to see whether the 821 transcript is going down. Now, please remember, whenever you follow a patient for minimal residual disease using transcripts, it has to be done serially, because the 821 translocation occurs at a stem cell level, and you can clinical study. And that is why you need to quantify the transcripts serially, and then you have to look for a trend before you actually take an action based on the molecular tests or the reports that come in. So, how do you work up an acute leukemia? Well, you get a morphology, you take an EDTA sample that goes to flow lab and goes to the molecular lab for DNA and RNA extraction, and a heparin sample that goes to the cytogenetic lab. So, if you do not have enough marrow, you can the heparin sample first goes to the cytogenetic lab. They put their share, put the the marrow for culture, and the same is then can be sent to the flow lab for immunophenotyping. Another case I just want to show just the importance of cytogenetics in hematological malignancy. Now, this was a patient presenting with low platelet counts, pancytopenia. She had weakness, bone pains, she had ecchymotic patches, and the clinical diagnosis really looked like acute promyelocytic leukemia. So, bone marrow aspirate and biopsy was done. What you see here in the bone marrow was a lot of necrosis, and you can see the morphology is not clearly visible here, and you look at the bone marrow biopsy, it is completely necrotic. So a diagnosis was thought, okay, let us send her to a PET scan. We are probably dealing with a metastatic disease, which has actually involved the bone marrow. And of course, the marrow came for karyotyping. And when we karyotyped this patient, we found a translocation 816. So what does then translocation 816 mean? So 816 is a specific subtype of acute myeloid leukemia. It is rare. It shows extramedullary involvement. It has frequent coagulopathy and is commonly mistaken as a promyelocytic leukemia. This usually presents as a monocytic leukemia, and that is why even on morphology it is mistaken as an APML. And in 60% of patients, there was coagulopathy, and a clinical and morphological diagnosis of APML was made in 8 out of 18 patients. Now, this is a high risk disease. You do see a lot of erythrophagocytosis when you have viable cells in these patients. Relapses are frequent after transplantation, and DIC is a prominent clinical features. And of course, because as I said, they present as monocytic leukemias, they can have a striking morphological resemblance to acute promyelocytic leukemia. So diagnosis of APML, as I said, can be done by FISH. You use a PML-RARA probe, a dual color, dual fusion probe. You get fusions. You are able to diagnose your APML. Sometimes you can get variant patterns, and you can use these variant patterns to identify variant translocation, like one of our patients that showed a translocation 1117. So you can actually use the PML-RARA probe. When you get 3 RARA signals, use a RARA break apart. Also, you must understand that APML classic on morphology and flow, and you get FISH negative. What do you do then? You must understand that in some of the APMLs, even when they are not variants, what you can get is you can get a PML RARA by small insertions. So do trust your morphological and flow cytometric findings to call something as an APML, because you get what is called as FISH negative morphological positive APML, and that happens when the PML RARA fusion transcript is formed because of very small insertion rather than translocations, and that is why you miss them on FISH. So what should be your workflow for APML? Send for karyotyping. Suppose it doesn't turn out to be an APML, karyotyping is essential for risk stratification of this patient. We always send for an RT-PCR also. If FISH for PML RARA, we report within 4 hours, positive for fusions, confirmed as APML, negative for fusion, extra RARA signal, put variant, put a RARA break apart probe, correlate with karyotyping, match metaphase and RARA break apart. And if you get a standard negative, then do an RT-PCR. If not, you do a next generation sequencing, and then you can identify the RARA variant. So APML, you can get fish negative as well. One should be aware of it and do not question your strong morphology and flow findings in such patients. So acute myeloid leukemia, cytogenetics only at diagnosis? No, you can also actually, cytogenetics can help you even at when you're following up patients with bone marrow transplant. So I like to call this case when you miss your X and you question why, right? So this was a 32-year-old patient of AML. He underwent a bone marrow transplant. Now the transplant was done. The donor was his haploidentical sister. So you must know that whenever we do a bone marrow transplant of a male recipient from a female donor, the hematopoietic cells from XY become XX. Just the hematopoietic cells. So all the cells that are coming from the bone marrow, so all your WBCs now, in case of a successful transplant, will become from a male to female, that is, it will become X from XY to XX. And this information is used by fish to follow up these patients. So, well, this patient was fine for 3 years, and then he presented after 3 years of transplant with fever and headache. Causes of fever, was it a viral fever? So we did a molecular path which showed complete chimerism. Bone marrow aspirate showed no tumor cells. Immunophenotyping showed dysplasia or dysmatopoiesis. And then we did a karyotyping. So when we did a karyotyping, as I said earlier, that in karyotyping, the tumor cells are cultured. They get an opportunity to grow. So even if there are but what we saw was we also got about 6 metaphases which showed an XY. That means the tumor was coming back, and the tumor cells also had a translocation 1122. We called back, I remember calling back Dr. Chandy and telling him, sir, he's going to relapse. Although there are no blasts right now, but he's going to relapse because the neoplastic XY clone has come back, and this time it's come back with a new translocation. So the patient was identified as a potential relapse even before the disease had relapsed, and was then given TNI, total leukocyte infusions, and then he went in for a second transplant, and now he's doing pretty well. From acute myeloid leukemias, I want to come back to acute lymphoblastic leukemias. And if there is one disease which is a real paradigm example as how genetic based risk stratification has improved outcomes, it is pediatric ALL. So you look at this. In 1970s, the outcome in pediatric ALL was 30%. And today, a standard risk patient of pediatric ALL has more than 90% outcome. And how has this been possible? This has been possible by risk adapted therapy using genetic risk as well as treatment response, that is your minimal residual disease. Although in all these years, in these 3-4 decades, no new drugs have come, it is just repurposing of their existing drugs. What has happened is we have been able to identify the genetic abnormalities, we've been able to identify the biology of the disease, and then risk stratify these patients. So patients with low risk genetics get low risk therapy, and patients with high risk genetics get much more intensive therapy. So in BALL, what are you trying to identify? You look at the number of chromosomes. If the number of chromosome is more than 51, it is good risk. The number of chromosome is less than 40, hypodiploidy, it is high risk. You're looking for an amplification, and IAM21 is high risk. And rearrangements of fusions, ETV6 Ranux1 or translocation is good risk. The BCR-ABL, MLL or KMT2A as it is called today, and E2A HLF are high risk. So how do you achieve this? So you can just use karyotyping, or since expertise to interpret karyotyping is difficult to find, you can use a combination of flow cytometry and FISH. FISH is much more easier to do. So you do a flow-based ploidy. It will tell you whether it is hypodiploid, hyperdiploid, or a normal diploid one. And then you use 3 probes. You use 1221, you use a KMT2 and MLL break apart, and you use a BCR-ABL. By using these 3 FISH probes and Using flow ploidy, you can actually risk stratify almost 70 to 80% of pediatric ALLs, right? Suppose you do not have flow ploidy, you can use centromeric probes to identify gains. So this is the strategy we use in Tata Medical. We use the 1221 probe, which not only identifies 1221 fusions, it also identifies IAM21, it also identifies high hyperdiploidy. So a single fish probe, you can identify risk stratify 55% of pediatric AL. Then you can use an MLL break apart, use a BCR able, and then of course karyotyping helps you to identify the ploidies, and flow ploidy you can identify the using the flow ploidy as well. So I was telling you, as the ETV6 Rannoxone fish probe that you see here, ETV6, which is on chromosome 12, is green. Rannox1 on chromosome 21, which is red. So normally you will get two copies of the genes, two reds and two greens. If there's a fusion, you get yellow signals. Now chromosome 21 is gained in 100% of high hyperdiploid ALLs. So when you get four copies of Rannox1, it indicates a gain of chromosome 21 and suggests the presence of hyperdiploidy. And when you get Rannox1 signals like this in clusters, it indicates an IAM21. Translocation location, they get separated. So fish, I want to tell you, is not only a quantitative test. Please don't use fish like a biochemistry test. What is the positive value or negative value? It is also a qualitative test. It is a semi-quantitative test. So this was a 4-year-old for ALL. Outside cytogenetics was negative. He had received some amount of treatment. Now, when we do fish, we have cutoffs. So for our MLL, the cutoff was 9%. So we got 2% cells positive, right? So, however, since we also karyotype at Tata Medical Center, in this patient, we got a 411 translocation, which is a high risk abnormality. And then this patient was put on high risk treatment. I just want to show you the importance that how multiple technologies can complement each other in identifying abnormalities which are very, very important and which make a huge difference in patient management. KMT2A is a very high risk acute lymphoblastic leukemia. These patients have get intensive chemotherapy unlike the standard risk one. Now, with the advent of next generation sequencing and high throughput sequencing technologies, by using RNA sequencing, at least 26 to 28 different types of ALLs have been identified, right? Now, sitting here with the resources, do you go about identifying all of them? Well, at least you should identify those which are important for risk stratification of therapy, like the hyperdiploid, the good risk, ETV6, Rannox1. Copy numbers, you have to identify the ERG deletions, which indicates a DUX4 rearrangement. And the red ones, what I'm showing you here. So identify abnormalities that are important for risk stratified therapy, and we must identify in a diagnostic lab abnormalities which have targeted therapy. So there are other subtypes also, like the PAX5 alt or PAX5 eta, which are the risk stratification is of intermediate risk in this patient, but these ones at least you should identify. So for summary for BCPLL, essential to identify subtypes associated with risk stratification and targeted therapy. Fish, flow, and if you have karyotype, can identify 70% of abnormalities. Of course, high throughput sequencing technology can be used, but here, what is a single platform? There is not much role of identifying mutations in BCPLL as of now, except for your TP53 mutation. But for NGS, you need to be sure, and RNA sequencing is coming up as one single platform wherein you can actually identify all the different subtypes based on gene expressions, based on fusions, based on copy numbers, and you can go about identifying targeted single nucleotide variants. Coming to the last bit, which is the multiple myeloma. So multiple myeloma, when you look at the biology of multiple myeloma, you must know that there are primary cytogenetic abnormalities and secondary cytogenetic abnormalities. So the IGH gene rearrangement and trisomy of chromosomes are primary abnormalities. They happen very early at the course of the disease. And once like 1q amplification or 1p deletion, deletion 17p, MYC can either appear as a secondary abnormality or can be present as primary abnormality. So whenever a patient comes for diagnosis, right, you have to first identify the primary abnormalities. Now the problem what I see in myeloma is people take the bone marrow and they directly fish it. You must understand that fish, as I said, you need to have cutoffs. So you have to enrich the plasma cells. So for anybody outsourcing the fish for myeloma, please ask whether the plasma cells were enriched before fishing. So what we do is we use a magnetic based suppression. We use CD138 antibodies. The CD138 antibodies with iron particles get attached to the plasma cells. You put them in the tube, you put it under the magnet, the plasma cells get clusters on the sides. Myeloma can be a patchy disease. So if you use direct marrow, you are really going to miss on a lot of abnormalities. Believe me, there are papers from India saying that Indian myelomas, the frequency of cytogenetic abnormalities is very low because Indian myelomas are different. It is absolutely wrong. The cytogenetic abnormalities in myelomas in India is similar to that seen in West. The point was we were not doing it the right way. So if you extract the CD138 plasma cells and you fish them, you will find abnormalities. So this is what we do in our center. We first use these four probes. We use an IGH break apart probe, wherein only when the IGH is positive, we go about looking for partners. So 614 or 1114 we do first if it is standard risk, and if that is negative, then we look for the high risk abnormalities. And then the other fish partners that are associated with high risk are CMYC, 1416 and 1420. So one of the ways, because you have to have a strategy in order to judiciously use the plasma cells that are enriched and also judiciously save money for the patients. So you can develop your stepwise strategy and then fish for these patients. Now let me show you an interesting case. Now, myeloma is a disease of elderly. Of course, you do see them in some young patients also. So this was a 72-year-old male with lytic lesions presented with high blood counts, which was suggestive of myeloproliferative neoplasm. So we did a peripheral blood fish, and then we got a BCR-ABL fusion positive. So when we did a bone marrow aspirate, this patient had 5% plasma cells, and of course, the lambda kappa chains were also deranged. So when we did a bone marrow biopsy, so we had two cores which were kind of intermixed. So in this core, you see a complete picture of a myeloproliferative neoplasm or chronic myeloid neoplasm, and here you see sheets of plasma cells that are positive for 138. So this patient who on peripheral blood was only suspected of having an MPN, but since he had lytic bone lesions, there was also a suspicion of myeloma. The bone marrow aspirate showed 5% plasma cells, and in marrow you could see sheets of plasma cells and mixed with a picture completely consistent with a chronic myeloid leukemia. Well, so we did a fish panel, and this patient had a 1p 19q deletion, right? And the BCR-ABL fusion was positive. Okay. So what we thought was we asked ourselves a question: are these two malignancies coming from the same tumor, from a same stem cell, or are they coming from two different stem cells? So are these two different malignancies or they're arising from the same malignancy? So what did we do? So what we did is we took the CD138 positive plasma cells and we put BCR-ABL on them. We got fusions, the BCR-ABL fusions, even on the plasma cells. So you were like, okay, we have a population of plasma cells which is showing BCR-ABL fusion. So the next question is that there was a BCR-ABL and then which was occurring at a very high stem cell level. So that is why it is also present in B lineage cells. And then from that B lineage cells, you got a myeloma. So we did, let us do one thing. Let us put both the probes on same cells. So we took the CD138 positive cells and we put BCR-ABL in 1P, 1Q, and we found both these abnormalities on the similar cells, showing that, well, the fusion as well as the myeloma abnormality are present in the same cell. So probably they are arising from the same cell. So what I want to show here is that you can ask simple questions. You know, when you talk about research, research is in your day-to-day cases. Of course, it is nice to do big-time research, write grants, but every case you get, you are actually doing a research on it. You are asking the right questions, and you can ask very interesting questions. Use simple techniques like fish to identify interesting questions. So this patient actually, probably the cell of origin for myeloma and the CML was same, and we are seeing the same genetic abnormalities in the same cells. Okay, so now I've talked to you about diagnosis, I've talked about risk stratification. What, where else can you use cytogenetics? So, you know, because I've worked in histopathologies, the floaters can be a big trouble sometimes. So I'll just show you a story of two cases we got in histopathology lab. Both of these patients were patients of acute lymphoblastic leukemia. One of these patients 46, right? And this is biopsy number 45. Okay. So what you see here, you see that there is complete involvement of the interstitial tissue in between the seminiferous tubules by the ALL cells. Whereas in this, you're seeing normal testicular tissue and you just see one bit which is looking like involved by the leukemia. Now the question is, this is 45, this is 46. So whether this bit in this patient came from this biopsy. So it was very difficult to sign out both as relapse. This of course is a relapse, but what about the other patient? This is how it looked, and it was positive, it was suggested of relapse. But what about this 46? Is this a true relapse, or is this a floater that is troubling you? So this was 47, this was 46, crossed on the same day. The number of bits are more or less same. So there was a big doubt there. So when we looked at the patient which had a clinical testicular relapse, this patient had a 1221 translocation. And a patient which had probably a floater, we were not sure, had a high hyperdiploidy. So we realized both of these patients have two different genetic abnormalities. So what did we do? As I said, you can use one single probe to identify both 1221 as well as high hyperdiploidy. As you can see here, we applied the 1221 on this patient that was positive, and the one with the suspected floater did not show fusion. What it showed was presence of 4 RUNX1 signal indicating it is a high hyperdiploid ALL. So this was not a floater, it was a true relapse, even though clinically the the testicular palpation didn't have a strong suspicion of relapse. So you can use cytogenetics even to solve these kind of troubles when you encounter in your lab. So to summarize, you need to integrate data, the clinical features, the WBC count, look at clinical features like organomegaly, presence or absence of CNS disease, treatment response, bone marrow features, immunophenotype, and of course integrate the karyotype as well as the molecular genetic features to come to a diagnosis. And I always say that this is almost there in almost all of my slides, that diagnostics or research is like a jigsaw puzzle. And this piece, what you're searching, may be in somebody else's pocket. So if you do not talk to each other, you do not talk to your colleagues in the same lab, if you do not talk to your colleagues in the other labs, if you do not talk to your clinical, all you know that this piece may be sitting in the pocket of one of your colleagues. And until you talk to them, you will not get your last missing piece and you won't be able to make your right diagnosis. So, Kung Fu Panda is my favorite movie, and I don't know how many of you have seen it. And Master Shifu always says there that if you only do what you can do, you will never be more than who you are. So, of course, you have to keep stretching yourself, put your stretch goals, try to learn new things, and apply them and implement them in your day-to-day practice. With this, I would conclude my talk. I would like to thank all the patients, the families, all my colleagues from clinical specialties, the molecular diagnostic. This is a hematopath lab. Yes, all of us have glasses in hands here. This is the cytogenetic lab. These are my whole cytogenetic team. This has was last year in the Durga Puja. We all come dressed in traditional. And this is the team of my old fellows. We had organized a meeting called all of them, and it is because of these fellows who keep asking me questions, keep me on my toes, and every time I hear a knock on my door with a fellow entering, I'm always scared what question they are going to ask, and I hope I have answers for them. I would like to thank our housekeeping staff, Sandeep. He makes great coffee, and he knows, he can identify chromosomes, he can identify fish patterns. You ask him what is the cytogenetic strategy for myeloma. He's not even a graduate, he's a housekeeping staff. He can answer you the fish strategy for ALLs, he can tell you what is the fish strategy for myeloma. So with that, thank you everyone. I would like to now invite Dr. friend and colleague, Dr. Dhanalakshmi, to conclude the session, and I will stop sharing. How do I stop sharing? Stop sharing here. Stop sharing.
Thank you, sir.
Yes, Dr. Dhanalakshmi, it's all yours.
Yes,
We have now
yes.
Dr. Dhanalakshmi with us. She has some very interesting quiz questions for students. Dr. Dhanalakshmi, please share your screen.
Yeah. Firstly, I would like to thank Mayur for such a brilliant and excellent talk as usual. I'm sure everyone is enlightened and knows a lot of cytogenetics. I'm here today, thanks to Dr. Gujral and the other pathologists. Here, just to give you simple questions, just to see whether you all could understand some of the basics of cytogenetics. Can you see my screen?
Yes, ma'am.
Yeah, so there are just 10 or 12, I think, questions, some very simple ones. If you all have understood the question, the entire talk, and these are simple questions, I'll be happy if you all could answer in the chat box so that we would just be able to discuss these further. Yeah. Coming to this first image, if you guys all can see, there is a left-hand image where you all can see these interface cells with one red signal. Now, the probe that we have used here is centromeric probe for chromosome 10. And what I can see here is one red signal, right? I can just see one red signal. This is a case of BLL, and if our audience here can tell us what could be the interpretation of this kind of a signal pattern that you can see here, just one red signal. So if the audience could just write in the chat box the answers, it would be good. At least we realize that yes, this is a case of BLL and we're just getting this one red pattern. So how would you interpret this when we're using a centromeric probe 10? Do we have any answers in the chat box?
Ma'am, there is one answer, deletion.
Okay.
Same chromosome deletion. Another participant has answered.
Okay. So when you call deletion, 10 chromosome, okay.
Someone has answered monosomy 1 and trisomy 10.
Monosomy 1.
And trisomy 10.
Okay. So
One participant has answered hyperdiploidy.
okay. So, okay. This image represents monosomy 10. See, we have two copies of the chromosome, right? Chromosome 10. So this is a centromeric probe and it is deleted. So what we would interpret it as is monosomy 10 for this image. Okay. Now coming to the next image here. Here you can see three signal patterns. Now, which is the probe that is being used here? This is a centromeric probe for chromosome 4 that is being used. Okay. And you can see three red patterns, three red signals here, right? Few cells, of course, there are two. You need to understand these are clonal abnormalities when you're talking about disease, a bone marrow disease. So here, when you see three red signal patterns, what would be the interpretation? I would request the audience to interpret. Now I think it will be easy. So I
Ma'am,
can see
answers are coming. Trisomy 4.
right. Fantastic.
Yes.
Yes.
Almost
Yes.
all
Yes.
have answered
Yes.
trisomy 4.
Right. So I think the first one was a bit of confusion, and now they've got it, and the answer is right. So let's move on to the next case. Okay, so this is a case of multiple myeloma. As Dr. Mayur has already explained, these are plasma cell disorders. Now, these are the plasma cells that are there in this image. And here what we have used, we have used a mixture of probes, which is targeting chromosome 5, chromosome 9, and chromosome 15. 5 being colored green, 9 being colored aqua, and 15, the color red has been given. Now, when you see this image of the cell, you can see several signal patterns, a mixture, right, of the green, the aqua, and the red. Now, when you look at this, what would you interpret this cell as, or the adjacent cell as well? What would be the interpretation? A basic question, and I would expect a basic answer to here. Audience, the enthusiastic audience. So here,
Sir, ma'am, answer is coming. Hyperdiploidy.
okay, which is right. Yes. Yes. Why hyperdiploidy? If anyone? Triploidy. Fantastic.
Diploidy.
Yes. Yes. So, okay, the audience is intelligent. And yes. So here,
Very much.
this is a triploidy. Yes. A trisomy of 5, 9, and 15, which is, of course, if it's seen as a sole abnormality in multiple myeloma, it could be a good prognosis. But usually these abnormalities are accompanied by high-risk markers also. So let's move to the next question. I'm happy that you guys are answering. This is a case of CML. Now, here the probe that has been used on these interface cells is the BCR-ABL probe, as Dr. Mayur has already explained. Okay, BCR is present on chromosome 22 and ABL1 on chromosome 9q region. So now, this is the probe that has been used, and this is the signal pattern which you can see, which is 2 fusion, right? 1 red, 1 green. Right? This is the pattern that I can see in my interface cells under the microscope. So what would I interpret this as? And most of them have the same pattern. So there is some answer. BCR-ABL fusion.
Yes, ma'am. BCR ABL fusion.
Translocation
Translocation
922.
922. Yes, ma'am.
Yes. So now since we are using the BCR-ABL1 probe, what I would interpret this is as positive for BCR-ABL, right? Rearrangement. Now, when you see 922 translocation is not wrong, but when I'm doing fish, I would rather use, because the probes are for the genes, and the genes are the BCR and ABL1, both on 22 and 9. So I would interpret it as positive for BCR-ABL1 and not translocation 922 here. But if you're doing the conventional karyotype, I would use the terminology as translocation 922. Right? Let's move to the next one. Okay, this is the case of AML. And here in these interface cells, the probe that is being used is the KMT2A break apart probe. The BCR-ABL probe that we used was dual color, dual fusion probe. And here we are using a break apart probe. Okay. And the signals pattern that I'm getting here is a 1 red, 1 green, 1 fusion pattern. Right. So what would be the the result, or what would you conclude after looking at this? The KMT2A is also the new term for MLL, which is present on the 11q region. Okay.
Yes,
Wow,
ma'am.
wonderful.
Those
I
are
think we
coming.
have a
MLL positive. Most
yes,
of the someone
yes,
has answered positive for KMT2A also.
yes. They are right. The answer is positive for KMT2A rearrangement. So we have a
Yes.
very good audience who has understood cytogenetics well. I'm glad about that. So here, this is one case. Now you can see one karyotype image here, right? And you can see a chromosome missing, right? You can see just one chromosome 7, right? So there is -7. So how would you, just give the result as when there is just a loss of 7? What could be? Yes, wonderful, wonderful.
Monotomy
Yes,
7 answer.
yes. Monosomy 7 is the answer. Fantastic. Now looking at the left-hand image, wow, we have got all the right answers on the chat box.
Yes.
Looking at the image on the left side, here we have used a probe, a triple color probe again for chromosome 5. Now this triple color probe is the P region of chromosome 5 is given the color aqua. The Q region, both the Q regions, the green and the red. Now these are two different regions just to understand whether there is a deletion or there is, and the triple color is used just to distinguish between a monosomy 5 and a deletion 5. So here, this pattern of 2 aqua, 1 red, 1 green, can someone tell us, or the audience tell us what the interpretation of the result would be? Deletion 5q. Okay.
Yes. Someone
Not
has
7q.
7q deletion also.
No, yes, it is
Majority
deletion
have
of,
answered deletion of 5q.
yes, exactly, right. Now coming to the right-hand side image of fish, here we have used a probe, a centromeric probe for chromosome 8, and this is colored green, right? And we're getting 3 signals, 3 green signals. So what could be the result?
Answers are coming, ma'am. Most of them have answered trisomy 8.
Yes, they are right. It's not monosomy 8, it is trisomy. You have got 3 signals, right? Now, could this audience also tell me what could be the disease where all of these abnormalities could be found? Monosomy 7, wow,
MDS.
very good. Yes,
Audience are answering.
yes,
Someone has answered
fantastic.
ALL
Probably
also.
I could ask some difficult questions here. Wonderful. Coming to the next one. This is slightly one step. I think Dr. Mayur has explained this wonderfully. And this is an image where we have used the ETV6 and RUNX1 probe. Dr. Mayur has already explained ETV6 present on chromosome 12p and RUNX1 present on chromosome. Wow, I've already got the answer before asking the question.
Yes.
And RUNX1 present in chromosome 21q, right? So here I can see 2 greens and 4 to 5 reds, right? And this is just a simple supporting probe that we have used here, telomeric 21q, which gives you 1 signal, or it could be 2 as well. So what is this indicative of when we use this? I think our audience is well read, probably not many lab people as well. Wonderful. Yes, the answers, many of them are right. And it is intrachromosomal amplification of chromosome 21, amplification of the RUNX1 gene. Yes. And this is a particular subtype, a very, very important, rather, subtype in the BLL, right? And is present in 2% of the population. Rather, it's very rare, I think. Coming to the next, I think I have just 1 or 2 more. And I'm very glad that the audience is very, very enthusiastic and is participating. So this is an image, and it's a cumulative image. I can say here this is a single case wherein one metaphase or several metaphase showing the abnormality where the chromosomal model number is 62. So this chromosome number is 62. Okay. And similarly, if you can see here on the right hand side, this is a probe used for telomeres 21, and here you can see 3 to 4 signals, right? And the same case also has metaphases wherein the chromosome number is 32 here, and similarly in the same patient, some of the cells are showing centromeric 4 as one signal, right? So this is the same patient where few are showing monosomies 4 here, and there is hypodiploid clone and also a triploidy clone, right? So there is monosomies and tritetrasomies in the same patient. How would you conclude it? And what would your interpretation be in this? It is slightly tricky. I saw some answers. I'm not sure what were those answers. Any answers?
Yes, ma'am. Someone has endo reduplication, and
Fantastic.
you have answered hyperdiploidy also.
Okay, so yes, when you look at 62 and when you look at 3 to 4 reds, yes, it is hyperdiploidy in terms of it is triploidy, tritetra, right? Signal patterns, yes. But this another phenomenon of the hypodiploid that is seen in the same patient is because this is a case of masked hypodiploidy, and which is also termed as endogene duplication. Okay. And now this is very, very important to, this is very, very important in BLL cases because this is very prognostic of poor disease or poor outcome. How also very important is one of these clones can proliferate, and usually it is a hyperdiploid clone, and this would be masked, the hypo would be masked. So fish could be an indicative that this could be a masked hypodiploid. So this becomes very important, and that's why I put this image. This is very simple. I'm sure there will be many answers here. It's the case of AML. And if you can see this karyotype, you could see some chromosomes that are abnormal. And I would want to understand the answer to this. You can see 8 that is abnormal. And you can see
Translocation
21 that is abnormal.
Yes.
Yes.
Most
Wow.
of the participants have answered translocation 821.
Oh, so then my questions are very easy. Wonderful. Excellent. Yeah, let's move to the next one. Again, I think very simple. This is a case of CML. And here you can see the classic 921, right? The 922, reciprocal translocation, balanced reciprocal translocation. However, along with this, what you can see here is a extra chromosome 8, which is trisomy 8. And what are the results? What is the answer? What is the abnormality that is detected?
Participants has answered trisomy 8 also, and
Yes.
translocation
So
922.
this is trisomy 8 along with the 922. And could someone say, let us know what stage of CML this could be? What could this be predictive of?
Someone has
Accelerated
answered
phase?
accelerated phase.
Yes, I could see some right answers. CML-BC, yeah, gas crisis, right? We'll move on to the next one. Okay, I think this is the last one. And this is a case of BLL, where KMT2A was positive by fish. Can someone identify what abnormality this is? And this is again shown by Dr. Mayur. The images were fantastic. So this is a simple example. It's very simple. And he said this is a high risk, right, rearrangement.
Someone has
KMT2A.
answered translocation 411. Ankita has answered.
Okay. Yes, it is the 411 translocation. Yes, I've highlighted everything. It was simple. And I think that's it. I'm done. Thank you so much.
Mayur, you are there. Excellent cases, and obviously preceded by Mayur's presentation. I really enjoyed your quiz, Dr. Dhanlakshmi. I think we should have more of you teaching kids, these beautiful slides. Hi, Mayur, are you there?
Yes, sir,
Can
I'm
you hear
there.
me?
I can hear you. Can you all hear me?
Yes,
Mayur,
sir.
yes. Mayur, there are hardly any questions. Students are flabbergasted. They enjoyed, I think, your talk and Dhanlakshmi's quiz. You have any final comments, anything which you would like to tell students?
So I would like to tell students, don't get scared of genetics. When I was an MD Path student, whenever genetics would come, I would say, "Yeah, exam mein nahi aayega," and never study that, right? So, and when I went to do this fellowships, I had to study everything which I had avoided studying during my pathology, right? So, don't get scared with it. It's very simple. It is just about understanding it and integrating with what you're doing. And if you want to pursue any of this, please remember you cannot be a half cytogeneticist or a half molecular pathologist. Now, it's a lot of hard work, it's a lot of dedicated work and time duration. So, you want to pursue this, please go and get trained under at CMC Vellore, under Dr. Dhanalakshmi, or under me at Tata Medical. There are multiple fellowships across the country today. So please don't become half. Don't come for 1 week and then say, "Well, I'm a molecular pathologist or cytogeneticist." Yeah. So please, if you want to train in them, there is a lot of scope for this. I get call at least once a week from various labs across the country and outside the country. Do you have anybody? Can you send someone to us? Right. So there are opportunities, and please see if you like it. But it's a lot of hard